Okay, the last point in the management is checking for maternal and fetal responses. So, DKA is actually responsible for acute kidney injury, respiratory distress syndrome, cerebral edema, coma, and then finally death in a woman in whom the DKA is not improved or not well managed, right? Okay, the management is or the monitoring is that you check the capillary plasma glucose and serum ketones with a 1 hourly assessment. The plasma glucose is checked till there is the ongoing fluid and insulin therapy, whereas the serum ketones are checked for the first 6 hours and it should have a decrease by 0.5 millimole per liter per hour as already mentioned. The bicarbonate, potassium, and pH in the venous gases samples should also be checked, but it should be checked only for the first 6 hours because the bicarbonate is not reliable then after the after the 6 hours because normal saline is given and that causes the hyperchloremic acidosis. The increase in chlorine level will actually cause the dilution of the bicarbonate and will cause a decrease in its level, so it is not reliable after the 6 hours. If the ketone meter is not available, then you can calculate the anion gap, right? It will show an increased anion gap of more than 12 milliequivalent per liter. After that, arterial pH is checked only in hypoxia and where the impaired consciousness occurs because it is increased only by 0.03 and is not very useful otherwise. Okay, then we said that the bicarbonate, as I already mentioned, that normal saline will cause a hyperchloremic acidosis, which will cause the dilution of the bicarbonate and will cause a decrease in its level, and it will have the normal anion gap metabolic acidosis. But in DKA, there is an increased anion gap metabolic acidosis, right? That the next acidosis was in DKA, so the ketones will combine with the bicarbonate, and because the bicarbonate wants to neutralize the ketones, and hence will result in a decrease in the bicarbonate level, right? And then there is another ketone that is called an important ketone, that is 3 beta hydroxybutyrate. So this will be converted into its form, that is acetoacetate, and the acetoacetate will appear in a few for a few hours in the urine even after the improvement of DKA, right? So it persists there for certain hours. Okay. The DKA will be resolved. Okay, sorry, the potassium levels. Decrease in potassium levels will not only cause the maternal arrhythmias but also the fetal arrhythmias, and the fetal heart rate will be normalized after 6 to 8 hours of DKA correction, right? Next is the fetal response. Well, it is yet to be established, but it is said that the mortality rate of the fetus will be 9 to 36%, and the morbidity will be higher, and it is mainly because of the preterm delivery because it results in hypoxic complications, as well as susceptibility to the 3 beta hydroxybutyrate and lactate levels, which will decrease the glucose uptake by the fetal brain and hence results in brain injury. Delivery of the fetus depends upon certain factors like the clinical status of the patient, the gestational age, the reports of the investigation, the fetal heart rate tracing, and it should be a multidisciplinary approach. Okay, before delivery, what happens is that the patient is already dehydrated and there is a decreased uteroplacental circulation, so that actually results in the acidosis of the fetus. So